Good morning, everyone. I am recording a video for the first time, so I hope this works. My name is Dr. Pinar Polat, and I am a sleep medicine specialist at the Children's Hospital of Colorado. And my background is in child neurology. And today I will be speaking to you about central hypersomnias in children. So we're going to start off with a case. This is a 12-year-old girl with a history of asthma, with a 1.5 year history of daytime sleepiness. Further in her history is she reports falling asleep in school 1 to 2 times per week during short car rides, and she's napping about 1 hour, approximately 2 to 3 times per week for the past 8 months. She's also has declining academic performance, whereas she was an A and B student previously. Now she's getting C's. She's also had recent weight gain of 20 pounds in the last 5 months, despite minimal change in her diet. And she sleeps around 9.5 hours per night. No snoring, mouth breathing, witnessed apneas, or restless sleep. She does have a consistent sleep routine and a consistent sleep wake schedule. And her prior medical history is pertinent for a history of eczema as an infant and no other medical history since then, with the exception of what's included here. So her family history, her mother has hypothyroidism, her father has obstructive sleep apnea, and she has a younger brother diagnosed with ADHD, which is attention deficit hyperactivity disorder. So on physical exam, she is obese. Her body mass index is greater than 96th percentile for age and gender. She's awake, no acute distress, a little tired appearing, yawning. Pupils are equal, round, reactive to light, extraocular movements intact, tonsils are 2+, and everything else is pretty much normal on her physical exam. So we'll come back to that case at the end of this presentation. So moving on to hypersomnia. So the clinical presentation of hypersomnia, I think the main point is excessive daytime sleepiness is really the hallmark symptom. You have to have this to really consider a diagnosis or have hypersomnia be on your differential. Excessive daytime sleepiness is generally thought of as a subjective sense of sleepiness, an increased tendency to fall asleep during times and situations where an individual would otherwise be expected to be awake and alert, increased nocturnal sleep need and or increased daytime napping for age, difficulty waking in the morning, and propensity to sleep longer when given the opportunity. So for example, on weekends. Now, excessive daytime sleepiness looks different depending on your developmental age. So in prepubertal children, it can appear very different than it does for adults or even adolescents or late adolescents. So in pubertal children, it can present as restlessness, hyperactivity, emotional lability, irritability, aggression, behavioral problems in school and at home, inattentiveness, difficulty with focus, or being withdrawn, isolated, and tired. In adolescence, it can appear as moodiness, disinterest, lack of motivation, seeming bored or depressed. So, differential diagnosis of excessive daytime sleepiness. So there are sleep-related diagnoses. So insufficient sleep relative to sleep requirement. This can be secondary to insomnia, insufficient sleep syndrome, behaviorally induced. sleep-related breathing disorders, sleep-related movement disorders such as periodic limb movements, circadian rhythm disorders, delayed sleep phase syndrome, which is not uncommon in adolescents, inadequate sleep hygiene. So this can look like the weekday or school week sleep schedule looking very different compared to the weekend, where a teenager might be waking up at 6 in the morning Monday through Friday, but then wakes up at 1 p.m. on Saturday and Sunday. Insomnia, we've already talked about. Of course, narcolepsy and idiopathic hypersomnia. So non-sleep related conditions associated with daytime sleepiness. This is not by any means an exhaustive list. This is just an example of a few common medical conditions, but there are a lot of medical conditions associated with daytime sleepiness. So asthma, epilepsy, hypothyroidism, chronic pain, central nervous system demyelinating disorders such as multiple sclerosis, neuromyelitis optica, depression, anxiety, other mood disorders, or psychiatric disorders. Of course, drug or medication, anti-seizure medication, selective serotonin reuptake inhibitors, and of course, pain medications such as opioids. So when thinking about excessive daytime sleepiness, of course, it's important to know the sleep requirement by age. And here I have a breakdown of the bell curve distribution for sleep requirement for each age group. So one important point I want to make that I see in my clinical practice pretty often is patients coming in with a complaint of fatigue or being tired. And of course, somebody has sent them to sleep because they think, oh, something's wrong with their sleep. They're tired or fatigued. And sometimes it's just misuse of the word, and other times it truly is fatigue. But it is important to try to differentiate between fatigue and sleepiness. And this can be really challenging for a few reasons. One, they can often be together. And two, because they're used interchangeably in the vernacular, sometimes patients or families can get confused when you ask them, are you sleepy or are you fatigued? So I often have to kind of give an example of what fatigue is and what sleepiness is, and ask the patient, do you feel like you're more fatigued, more sleepy, or both? So again, it's often a co-complaint with excessive daytime sleepiness, but strictly by definition, fatigue is not an increased propensity to sleep, does not mean you are decreased in terms of your alertness or you have a shortened sleep latency. It is rather a subjective sense of lack of energy, abnormal level of exhaustion following normal activities, and or cognitive fatigue. And it's more likely associated with psychiatric and mood-related conditions. There are several validated questionnaires to get data on whether a patient is sleepy or not. And one of the most common ones that we use in practice, which I'm sure you all are familiar with, is the Epworth Sleepiness Score. And this is the modified pediatric sleepiness scale, and it can be used for children ages 3 and above. And so you can see here there's 8 different situations or scenarios, and you ask the child or adolescent or the parent, in the case of a younger child, how likely that child would be to fall asleep in any given situation on average. So for example, you're riding in a car for an hour without a break. 0, never fall asleep in that situation. 3, high chance of falling asleep, and 1 is light, and 2 is moderate. And then you basically score each one of those 8 scenarios for a total out of 24. And then here to the right, you can see how you would basically interpret that score. So essentially, anything higher than 10 is considered to be excessive daytime sleepiness, mild, moderate, and severe. The Epworth Sleepiness Scale, although one of the more commonly used one, is not the only validated tool. There are many others. There's the Pediatric Daytime Sleepiness Survey, Pediatric Hypersomnolence Survey, the Pediatric Narcolepsy Severity Scale, and the Idiopathic Hypersomnia Severity Scale. So going on to our topic of discussion, central hypersomnias, these are all of them. So there's narcolepsy type 1, 2, narcolepsy due to a medical condition such as demyelinating disease, genetic, Prader-Willi syndrome, idiopathic hypersomnia, and of course, Klein-Levin syndrome, which is very, very rare. So generally, when you're evaluating a child or an adolescent who comes in with a main complaint of excessive daytime sleepiness, as with anything else, history. So really digging into the history, sleep history is important. Sleep opportunity, sleep wake schedule, common things being common, especially, I'm not sure about India, but in the US, chronic sleep deprivation is basically epidemic, and a lot of adolescents are sleep deprived. So really being able to get a good solid sleep history about their sleep opportunity. And of course, their sleep wake schedule, again, not to harp on the teenagers and adolescents, but they're the ones that are most likely to have a significant change in their weekday schedule compared to their weekend schedule, which can basically, cause a phenomenon called social jet lag. So for example, if you're waking up at 1 p.m. on Saturday and Sunday, and then you have to wake up at 6 a.m. on Monday, that can really make you feel fatigued, almost as if you've changed time zones and you're jet lagged. Of course, primary sleep disorders such as obstructive central sleep apnea, periodic limb movements, hypoventilation, sleep-related hypoxemia. Of course, again, other medical problems, hypothyroidism, chronic pain. Some things that we see often here is postural orthostatic tachycardia syndrome. And another one that we see pretty often is hypermobility syndromes. And those do have high incidence of fatigue in the absence of sleep disorders. So one thing that's really helpful is a sleep log. So asking a patient to keep a 2-week sleep log. It's hard to recall your sleep schedule, how long it takes you to fall asleep, how many times you wake up, how long it takes you to fall back asleep. And so really trying to collect that data prospectively can be really helpful to see how much sleep somebody's getting and how consistent their sleep schedule is. And if you have the ability to do actigraphy, even better. So actigraphy actually allows us to have objective data on those sleep schedules and how sleep duration, when does somebody fall asleep, when do they wake up, when do they nap, and it's essentially a watch that you wear, and it's very similar to, a Fitbit or an Apple Watch that kind of can track your sleep wake cycles, and it just provides that more objective data. So, of course, an overnight polysomnogram, and if you do, have a high suspicion for central hypersomnia, of course, you can do a multiple sleep latency test as well. So the general diagnostic criteria for hypersomnia in general, with the exception of Klein-Levin syndrome, is, of course, having the history of daytime sleepiness that is negatively affecting daytime function, so academic, work, social, having ruled out other possible causes of excessive daytime sleepiness, including insufficient sleep, and then, of course, multiple sleep latency test with sleep onset latency of less than 8 minutes. And this is assuming that, again, you've ruled out other causes, including other sleep-related causes, which includes the sleep-related breathing disorders with an overnight polysomnogram. So moving on to narcolepsy specifically, there's two types. There's narcolepsy type 1 and there's narcolepsy type 2. And the difference between the two is that narcolepsy type 1 has cataplexy and narcolepsy type 2 does not have cataplexy. From a pathophysiology perspective, narcolepsy type 1 is associated with CSF orexin levels less than 110. And narcolepsy type 2, you can have normal or decreased CSF orexin levels, but it's not necessarily less than 110. So as far as epidemiology goes, the incidence of narcolepsy type 1 is about 1.2 per 100,000 persons. The prevalence in the US and Western Europe is 0.025 to 0.05. In Japan, a little higher, 0.16, and in China, 0.28. So you can see it is quite rare. And I did not look up the prevalence in India, and I don't know if any of you know what the prevalence is, but I do remember in a prior session, I was told it's pretty rare in India. There is a 1 to 2% risk if a first degree in first degree relatives of the person affected with narcolepsy. And narcolepsy type 1 is 70% of all narcolepsy cases. With narcolepsy type 2, the incidence and prevalence is not uncertain, and it's considered to be 15 to 20% of the narcolepsy population. There is a slight male predominance, actually, in both type 1 and type 2, and a possible predilection for relatives of narcolepsy type 1. Now, just a side note here, sometimes a person will be diagnosed with narcolepsy type 2 because they don't have the symptom of cataplexy. But oftentimes, cataplexy is a later symptom. So the excessive daytime sleepiness can be before cataplexy by anywhere from 6 months to several years. So sometimes somebody might get a diagnosis with narcolepsy type 2, and then a few years later actually start to get cataplexy events. And at that point, you would change their diagnosis to narcolepsy type 1. And it doesn't mean that their disease or condition changed. It just means they were always a narcolepsy type 1, but the cataplexy had just not manifested yet. But the opposite is not true. You don't go from being a type 1 to type 2. So age of onset, as you can see here, it's thought to typically be in the sort of pre-adolescent, adolescent years. And we're looking at data from A is France and B is Canada. So the diagnosis of narcolepsy is typically delayed by a mean of approximately 12 and a half to 15 years after onset of symptoms, which is really unfortunate, likely due to poor symptom recognition, especially in children. And often it can be misdiagnosed as depression due to inattention, difficulty with focus, poor motivation, psychosis, especially when the sleep-wake transition hallucinations are a prominent feature, conversion disorder or functional neurologic disorder, attention deficit hyperactivity disorder, and epilepsy. So the cataplexy can be misdiagnosed as, for example, drop attacks or drop seizures. So clinical presentation, we already talked about this a little bit, but daytime sleepiness, really it's kind of got to be there in the many ways it can present. You can have microsleeps or sleep attacks. Other common symptoms are sleep paralysis, hypnagogic and hypnopompic hallucinations, cataplexy, again in type 1, restless sleep, vivid dreams, and acting out dreams. So we already talked about excessive daytime sleepiness ad nauseum, so I'll skip this. So cataplexy, let's talk about cataplexy a little bit more. So transient sudden loss of bilateral skeletal muscle tone with retained consciousness. Retained consciousness is important to differentiate it, for example, from seizures or other disorders. Most commonly in response to a strong emotion, positive emotion such as laughter or surprise being more common than negative, anger, frustration. It can last seconds to minutes. Sometimes it can occur in clusters. Typically, jaw slackening, slurred speech, head or shoulder drop, or buckling of the knees. Atypical would be tongue protrusions, ptosis, gait instability, and repetitive tongue thrusting or mouth opening. The typical and atypical delineation is really more for adults. Children, what's typical for children is actually what's atypical for adults. So here we go. So cataplexy in children, so common presentation. So active, overactive motor phenomena, especially of the tongue and perioral muscles. So again, that tongue thrusting. Facial hypotonia, droopy eyelids, mouth opening, protruded tongue. We call this a cataplectic facies. So a child might kind of look like that. Falling or tripping, irritability, restlessness, inattentiveness. So to the right, you can see some examples. So one of the other symptoms is sleep paralysis. And I have this quote from actually one of my own patients who said, your mind wakes up, but your body doesn't, and really captures sleep paralysis very succinctly and accurately. So it's an inability to voluntarily initiate muscle movement except extraocular and respiratory muscles. So patients are able to move their eyeballs, they can still breathe, but otherwise are completely paralyzed. So again, they're fully conscious, can last for a few seconds to a few minutes, frequently accompanied by hypnopompic hallucinations. So patients will commonly describe incubus, intruder, and unusual body experience. And I have a picture here to the right that it's an artist's depiction of sleep paralysis, and looks very very scary. And if you were to actually look up sleep paralysis in art, you would come up with a lot of depictions that actually look very similar. So causes extreme anxiety with fear of dying. As I said, your respiratory muscles are still able to move, so diaphragmatic activity continues. And just as a side note, this isn't pathognomonic for narcolepsy. Approximately 7.6% of the general population experience at least one episode of sleep paralysis in their lifetime. So it can be an isolated phenomenon unrelated to narcolepsy. So hypnagogic and hypnopompic hallucinations. One easy way to remember this: hypnagoing to sleep versus hypnopompic, waking up from sleep. So these are hallucinations that occur right at that sort of blurry boundary between sleep and awake. Can be visual, tactile, auditory, or multisensory. So patients will report seeing shadowy figures or feeling something kind of crawling on their skin. Typically do occur more upon awakening than while going to sleep, can last a few minutes, and may contain elements of dream, sleep, and consciousness, and are often bizarre and disturbing. So other common symptoms are sleep fragmentation. So fragmented nocturnal sleep, repeated awakenings, vivid dreams, and dream enactment, which can sometimes seem counterintuitive when you think about narcolepsy as a condition that is characterized by excessive sleepiness. It can seem counterintuitive that you also have fragmented and restless sleep as well. So other things kind of associated with narcolepsy, patients with narcolepsy have a lot of comorbid sleep problems, more so than patients without narcolepsy. So obstructive sleep apnea, periodic limb movement of sleep, REM sleep behavior disorder, This is one of the few times you'll actually see RBD in the pediatric population. In general, it's more a population of the elderly. But with narcolepsy, you can actually see it. Comorbid medical and psychiatric problems, so ADHD, depression, anxiety, obsessive compulsive disorder. And I'm not sure why I put obesity here, but weight gain and obesity as well, which then, of course, puts them at risk for obstructive sleep apnea. So one thing I'm going to talk about now is, we really focus on kind of the clinical features and the diagnostic criteria, but it's really important to consider the patient perspective and kind of the disease burden or burden of disease and the toll that this takes on patients, especially young children, adolescents, especially if they haven't been diagnosed. So this is really looking at a patient's perspective, kind of the things that are important to them, the things that bother them the most. So here in the top graph, A, so these are core narcolepsy symptoms rated by youth and parents. So youth and parents really rated what's the most disabling symptom. So first is daytime sleepiness, which is not surprising. And then it's actually disrupted nighttime sleep, which is a little surprising. And then third, you've got depression and mood changes. Fourth, you have cataplexy. And then last, you have sleep-related hallucinations. And then we have here the psychosocial challenges, which kind of go along with the previous slide. So what's really challenging about narcolepsy, and I'm sorry if the print on here is much smaller than I initially thought it was going to be, but looking at the top graph, psychosocial challenges, the dark lines are youth report, the right lines are parent report. So they pretty much correlate with each other, but the most prominent one, the first one is difficulty focusing and memory. The second one is worry about the future. Third, schoolwork. Fourth, easily upset. Fifth, diet and nutrition. So it's interesting, right, that the second psychosocial challenge is worry about the future. So really important to understand what patients and parents are concerned about. And then when you look at psychosocial challenges, physician report, it doesn't really correlate with the concerns of the patients. So you can see it just doesn't follow the line of the patient. So I think it's important for us as physicians, providers, to really be aware of what it is that our patients and our families are most worried about, and to worry about those with equal intensity. And that's for anything, not just narcolepsy. So kind of on a similar related note, this article looked at clinical characteristics and burden of illness in pediatric patients. And looking here, you're looking at narcolepsy patients compared to a group of control, and you're looking at grades and quality of life. So the top graph is grades. So the top graph, the first lines are grade repetition. And you can see narcolepsy patients 26.6% repeat a grade compared to 7.6% of controls. School difficulties, 41% report school difficulties compared to 7.5% of those in the control group. And then absenteeism, 30.4% absenteeism compared to 9% in the control groups. And then in the one underneath that, the graph underneath that, we have quality of life measures. So for children, quality of life, 59% compared to 76 to control groups, adolescents 60% compared to 69 in control groups, and for parents 61 for those parents who have a child with narcolepsy compared to 73 for those parents who do not have a child with narcolepsy. So quality of life is definitely impacted. So the diagnostic criteria for, so moving kind of to that different end, right, that kind of more clinical part of things. So of course the clinical history, the sleepiness questionnaires, whichever it is you use. Again, Epworth sleepiness scale is the most common, but there are other validated questionnaires. Overnight polysomnography followed by a multiple sleep latency test of the MSLT, a 2-week sleep log and or actigraphy 2 weeks prior to the polysomnogram and MSLT. So normal polysomnogram that rules out other sleep disorders. So for example, if you do a polysomnogram and you have an obstructive apnea hypopnea index of 25 in an 8-year-old, you wouldn't actually proceed with the MSLT because that alone could explain the sleepiness. But as long as you have a normal sleep study, overnight sleep study, you go on to the MSLT. And that is basically, for those of you who might not know, that is 5 nap opportunities in the morning following the overnight sleep study, 20 minutes each, 2 hours apart. And what we're looking for is the propensity to fall asleep. So the sleep onset latency. And if the average sleep onset latency for all 5 naps is less than 8 seconds, that is a diagnosis of hypersomnia. Now, in addition to that mean sleep latency less than 8 seconds, if they also have 2 or more sleep onset REM periods during the MSLT, or 1 SOREM in the PSG and 1 SOREM on the MSLT, that actually counts. And a SOREM on the polysomnogram needs to be a REM onset in 15 minutes or equal on the overnight polysomnogram. And or if you're able to, a CSF hypocretin level of less than or equal to 110. We here in the US don't typically check hypocretin or orexin, they're interchangeable levels. But you can. There are certain labs and places that you can do this. And a CSF hypocretin that's less than or equal to 110, along with supportive history, would be diagnostic even in the absence of sleep study and MSLT. So diagnosis supporting evidence. Things aren't always really clear cut and black and white. So there are some things that can kind of support the diagnosis of narcolepsy. So REM without atonia is a marker for pediatric narcolepsy, not diagnostic. When would this be useful? So for example, you got a polysomnogram on a patient with mild daytime sleepiness, but also snores. Didn't have sleep apnea, but you did notice REM without atonia. This might raise your suspicion for narcolepsy. Again, it's not diagnosis, but on follow-up visit, you might want to inquire a little bit more deeply to see if there are more symptoms that pop up that would make you think of narcolepsy. Other polysomnogram findings that are supportive, decreased sleep efficiency. So like I said, a little counterintuitive where you have this propensity to sleep, but then you have a pretty decreased sleep efficiency. I am pretty skeptical of a diagnosis of narcolepsy if I have an overnight polysomnogram with a normal sleep efficiency, meaning 85% or greater. Restless sleep, so on the polysomnogram, this can look like increased arousals, increased arousal index, and then genetics. So HLA DBQ1 0602 is associated with narcolepsy, but it is not diagnostic. So 90% of patients with narcolepsy type 1 have this gene. And however, 10% of patients without narcolepsy also have it. So it's not diagnostic, and its utility is really when you might have some inconclusive MSLT results in a patient who really is sleepy, whose MSLT had a sleep onset latency of 9, or a patient who you couldn't stop SSRIs on, they're REM suppressing agents, and you have a high suspicion, but they didn't have 2 SOREMs, but you think it was maybe because they were on a REM suppressing medication. In those cases, you might want to do an HLA-DBQ because it might tip the balance, if it's positive towards a diagnosis of narcolepsy type 1. So here's an example of an MSLT. So you can see 5 naps, sleep time, sleep onset, REM onset. And so for this individual, they fell asleep in all 5 naps, and their average sleep onset latency was 4. And they actually had REM on 4 out of the 5 naps. So as long as their polysomnogram was normal and they have a history of excessive daytime sleepiness, and really nothing else accounts for this, so no, significant chronic sleep deprivation, this would be a diagnosis of narcolepsy. So the pathophysiology of narcolepsy type 1, it's considered to be autoimmune. Loss of orexin secreting neurons in the hypothalamus, again with that CSF orexin levels being less than 110. We talked about HLA-DQB10602. This is just a diagram of the lateral hypothalamus. So as far as the autoimmune etiology goes, 90% of patients, like I said, were positive for HLA-DQB1. 12 to 38% of the general population is positive, highly sensitive, not highly specific. There has been reported recent increases in narcolepsy, one with streptococcus, influenza A, which is the H1N1 virus, and monovalent H1N1 vaccine used in Europe. So the thought is that you have a genetic predisposition, like many other autoimmune disorders. You are exposed to a pathogen or a vaccine that cross-reacts with that creates antibodies that cross-react with the neurons in the lateral hypothalamus, attacking those neurons that make orexin, and then basically permanently injuring them. So we didn't talk too much about secondary narcolepsy, and we haven't talked about idiopathic hypersomnia yet, but I like this because it really kind of breaks down type 1 and type 2. And so again, they both have a positive MSLT, both have excessive daytime sleepiness, but the difference is one has cataplexy and the other doesn't. One has definitively low CSF hypocretin, the other, it can be low, but it doesn't have to, it can be normal as well. So treatment of narcolepsy, first and foremost, just like any other patient who comes into the sleep clinic, you want to optimize sleep hygiene. So making sure we have adequate sleep opportunity, a consistent sleep-wake schedule, any of the poor sleep habits and behaviors that negatively impact non-narcoleptic patients will impact narcoleptic patients as well, and even more severely because they already have a predisposition to being sleepy. Academic accommodations are a big one. There's many different types of accommodations. One of the most common ones is scheduled naps. So short naps, anywhere between 5 to 15 minutes, can be quite refreshing and rejuvenating for patients with narcolepsy. So really working with the school to schedule these naps at a time when the patient generally feels really sleepy, and that is different from person to person. So of course there are pharmacological treatments, wake promoting agents, anti-cataplectic agents, and really important that psychosocial support, right? We demonstrated how there's a large burden of illness and lots of psychosocial challenges. So really supporting patients with those challenges. So approved medications for narcolepsy, this is slightly outdated. So for excessive daytime sleepiness, we have modafinil, armodafinil, we've got pitolisant, sodium oxybate or Xyrem, low sodium oxybate. And now to add to this list, at least in the US, came on the market in May of this year. We have Lumryz, which is once a night dosing, sodium oxybate dosing, so extended release sodium oxybate. We've got solriamfetol and, of course, stimulants, so methylphenidate, dextroamphetamine. These are in the US, they're called Ritalin and Adderall, are their brand names. And so for cataplexy, also sodium oxybate, low sodium oxybate, pitolisant also works, and again, Lumryz, which is the extended release sodium oxybate. And then, of course, SSRIs are used as well, venlafaxine being one of the most effective ones, looking at the literature. But you can also use Effexor and sertraline and a lot of other SSRIs. So this is basically the same thing. I'm not going to go too much into this. Again, I don't know how much narcolepsy this audience treats, but this might be an unnecessary level of detail. But modafinil, the mechanism of action is increasing dopamine. And sodium oxybate, which again comes in 3 forms now: sodium oxybate, low sodium oxybate, and extended release sodium oxybate. Pitolisant or Wakix, mechanism of action is it's a selective histamine receptor antagonist. Solriamfetol or Sunosi, different mechanism of action, selective dopamine and norepinephrine reuptake inhibitor. And it's indicated for narcolepsy as well as residual sleepiness and obstructive sleep apnea. So for patients who have sleep apnea, who are treated with CPAP, are compliant with their CPAP, for example, they still have daytime sleepiness, solriamfetol could be used to help with that residual daytime sleepiness, even in the absence of narcolepsy. So shifting gears a little bit to idiopathic hypersomnia, there's kind of 2 phenotypes when you look at the literature. Idiopathic hypersomnia with prolonged nighttime sleep. And this phenotype is characterized by pervasive excessive daytime sleepiness, prolonged nocturnal sleep duration, so usually 10 to 12 hours, good quality nighttime sleep, so no complaints of restless sleep, frequent awakenings, that kind of a thing. Sleep inertia, so waking up in the morning and just really feeling like they can't wake up. So reduced vigilance during minutes following arousal in the morning or after a nap. And a kind of excessive time to be fully operational and sometimes even mental confusion when they wake up. Daytime naps, if they do occur, are typically long and unrefreshing. So unlike patients with narcolepsy who might take a 15-minute nap and feel pretty rejuvenated, someone with this phenotype of idiopathic hypersomnia may take a nap for an hour and a half and not really feel rested after the nap. So the second phenotype for idiopathic hypersomnia is idiopathic hypersomnia without prolonged sleep time. And this is characterized by nighttime sleep, which is normal in duration, so more than 6 hours and less than 10 hours. No significant sleep inertia, so they wake up and they don't necessarily have this difficulty sort of going online, if you will. And daytime naps, similar to narcolepsy, are short and refreshing. The diagnosis of idiopathic hypersomnia is similar to narcolepsy, so history of daytime sleepiness, ruling out other causes of daytime sleepiness. And as long as you rule out those other causes, if you've gotten an MSLT, sleep onset latency of less than 8 minutes, you don't need to have a history of cataplexy, and you don't need any more than 1 SOREM on the MSLT. Actually, you don't need to have any SOREMs, and if you have more than 1, then you have a diagnosis of narcolepsy. So different from narcolepsy, type 1 and type 2, which are both chronic lifelong neurologic diseases without cure, Idiopathic hypersomnia, up to 50% of patients demonstrate resolution over time. I couldn't tell you what sort of the average time frame for resolution is, but it does resolve for 50% of patients. So the important point there is if you do have a patient with idiopathic hypersomnia, at some point you probably do want to repeat overnight PSG with MSLT because you might not want them to be on wake promoting medications indefinitely if they don't need them. So unlike narcolepsy type 1 especially, for which the pathophysiology is really clearly defined, for idiopathic hypersomnia, it's largely unknown, thought to be possibly a circadian or homeostatic dysregulation or disturbance in the brain arousal system. Treatment very similar to narcolepsy, with the exception there are no anti-cataplectic agents, but the wake promoting agents are pretty similar. So last but not least, very rare central hypersomnia called Klein-Levin. So this is a relapsing remitting episodes of severe hypersomnolence associated with behavioral and psychiatric disturbance and cognitive abnormalities and hyperphagia. So the episodes are characterized by sleeping 16 to 20 hours per day. And while awake, characterized by confusion, amnesia, patients may report a dreamlike state, psychomotor slowing, apathy. They're just not quite themselves. The median duration of the episodes are about 10 days and recur every 1 to 2 months. And between the episodes, the patients are completely at their baseline. So awake, alert, they don't have daytime sleepiness, they don't have this mental confusion, hyperphagia, other sort of symptoms of altered mental status. And there is typically a history with a triggering factor such as illness, often reported. It's very rare, so it's a diagnosis of exclusion. Oftentimes, patients who present with this will have gotten an EEG, which will be normal, an MRI, a polysomnogram. You do need to have at least 2 episodes lasting between 2 to 5 weeks that recur at least every 18 months for diagnosis. Again, between episodes, normal mood, cognition, and behavior. During episodes, at least 1, in addition to the sleepiness, cognitive dysfunction, altered perception, eating disorder, so the hyperphagia, disinhibited behavior. You can have hypersexuality. And of course, the symptoms are not explained by another sleep disorder, medical or psychiatric. So no bipolar or autoimmune encephalitis or anything like that. I'm not sure how likely you'll come across a patient with Klein-Levin, but the treatment is lithium is considered first line, and the aim of lithium is to decrease frequency and duration of episodes. Alternatively, modafinil, and stimulant wake promoting agents can be used specifically during episodes to kind of combat that sleepiness. However, patients, both in the literature and anecdotally, will report that although the modafinil, armodafinil, and the stimulants can help them be more awake during episodes, it doesn't necessarily help with all the other symptoms, the kind of confusion, the altered mental state, the dreamlike state doesn't really help with those. So although they're awake, they're still quite not functioning at their normal capacity. And then there have been anti-seizure medications that have been used, valproic acid, lamotrigine, and carbamazepine, with variable levels of efficacy. So natural history of Klein-Levin, the episodes decrease over time in frequency and duration and spontaneously resolve after a median of 14 years. And that is it. So thank you very much. And if you have any questions, please send them my way, and I'm happy to answer questions via email. or whatever mechanism works best. Thank you so much.